Are you going to... Right, I've got something now. We're being live streamed.
You're live streamed. Okay. I'll share with you.
Okay, so welcome everybody to the Rotherham Integrated Care Partnership Place Board. This is our monthly meeting. Just a couple of housekeeping items, just on agenda item for the Provider Alliance update. We're going to defer that to the next meeting. And also under communications to partners, agenda item 6, I'm just going to ask partners just to update on system pressures as well. So if we can just be ready for that. So just coming back to our agenda then. So I'm Chris Edwards, I'm the chair of the meeting. I shan't go around introducing everybody because the names should be on the screen so work out who everyone is. But if people can introduce themselves as they introduce items or come in, that would be much appreciated. So has anyone, we've got apologies from Dr. Cullen, Councillor Roach, Sharon Kemp and Richard Jenkins. Is there any other apologies anyone would like to record? Okie doke, thanks everybody. Any conflicts of interest to record? No. Okie doke. And in terms of patient and public questions, I don't think we've received any this time, but if anyone who's watching this video has any questions, please send them in to us and we're happy to take any questions if you can submit them before the meeting. Okay, so we'll just move to our business items now. So we've got some transformation group updates. The first one's from Children's and Young People on mental health and emotional well-being. Who's going to take that? Who's the best person? Is that you, Christina?
Sorry, yeah, to mute, yes. I don't know if it's me or Susie, but I can't see her, so it's me.
I think it's probably you. I think, have we got apologies from, I haven't had apologies from Susie, but I'm not, oh, we have a,
yes, we have just had apologies from Susie, yes, sorry.
Okay, thank you. Sorry about that.
No, it's fine. Is the is the PowerPoint coming up? Because I've sent an actual slide deck.
Okay, so people have got it in their papers, haven't they?
I can share it on screen if you need to.
Please, Gordon, if you would. And Christine, if you just want to nod to Gordon when you're ready to move slides.
Just pop it, get it up now.
So this is the spotlight on children and young people. So I'm just giving you, it's a 3-slide update. Putting you under pressure, Gordon, now, aren't I?
No, I'm panicking trying to get it up.
So what I'll come up with while Gordon's doing it, just for time. So what's working well for us is the transformation of services, that we're going to a 24/7 crisis and community service. We've got additional investment for that. The model's under development and we're currently, so it's slide 2, Gordon, please. So we're currently looking at a mobilisation plan in place to support that transformation. That'll mean that our families, at the minute, we've got a Monday to Friday service with an on-call after hours. And what this will mean is that where we've got children who we need to be seen over the weekend or in an evening, we'll be able to see them much quicker. So that's underway. It will take us some time to recruit to that, but this is in the long-term plan and what we're going to initiate. We've also, through COVID, we've got a blended hybrid method of contact now. So COVID did force us to be more creative in the ways that we engage with young people and families. And the learning from that is that there should be a choice around engagement. It enables us to continue to deliver care when young people and families and practitioners are isolating. And it's created in efficiencies for staff in respect of less travel, for example, to meetings or for families. But the other thing, as I say, for families is some families were having to get 2 buses to come to our Kimberworth site. So now at the first contact, we ask families how they would want to be seen. And then we come up with some kind of negotiations, and it's individualised to those families. So it might be that we see somebody every 3rd contact, or it might be that actually we see how it goes and we do digital, we work on the video contact, which, to be fair, when people are having to, not only the time to get to the clinic, but actually the cost as well. We're looking at our neuro pathway redesign. We've worked with partners, and that's been for quite a while that we've been working on this design. We're now in an 8-week pathway. Before it were a 15-week pathway. We do a multi-agency working through a weekly panel meetings, and so there's a shared understanding of a graduated response and then support available for families. And this links to the development of the Senko online resources as well. We've got a digital pathway for our neurodevelopment assessments. It's called Helios, the firm that deliver this for us. We tried it tentatively about a year ago, and this is now an offer to families. It means that they're not waiting as long on the waiting list. There are criteria to send to Helios, which families we can send, but it's certainly getting really good feedback from families. The mental health support teams, we've got 23 school settings, and we're engaged in our Trailblazer pilot. That's primary, secondary and pupil referral units. And we've also got a mobilisation plan developed to support the rollout to a number of other school settings, and the rollout will commence in January. And it's a 12-month mobilisation period. Work's underway to identify schools that will be included in the next wave. Next slide, Gordon, please. So what are we worried about? And everybody will know that our waiting times for our ASD and ADHD assessment is unacceptably high, which is currently we've got 1,695 children waiting for assessment against a projected position of 1,721, and our longest wait is 196 weeks, which is unacceptable. So we've changed a lot of the pathway, we've changed the way we do things, and I'll come on to what we're doing about it on the next slide. Our referrals have just slightly gone down, 395 referrals since April against a projected 464, but we do tend to have peaks and troughs with referrals into the neuro, as we do with CAMS, based on school settings and school holidays. So we tend to get quite a lot one month, and then it reduces, and then we get more. So CAMS pathways, the place confuse long neuro waits as CAMS waits. So you often hear, oh, there's a long waiting list in CAMS, when actually the long waiting list is in the neuro pathway, as I've just described. So we've done work with Anna Freud. The rollout of the LINK programme has had some positive effect and impact on that. And what it's done is helped partners understand the different elements of the CAMS service. We've been able to explain that much better. So what we want to do is almost get away from that narrative that there's long waiting lists in CAMS in Rotherham, because there isn't. There's long waiting lists in the neuro pathway. And then the long-term impact of COVID. This is probably no different to adults, but the impact of poor parental mental health on children and young people is being realised, and that is what is coming through into some of the clinics about what's happening for families, job loss, all the things, you know, isolation, poverty, all the things, and that is impacting on the child. And then we've got obviously things like school, uncertainty around school. We've got bereavement, all the things that you would expect, but this almost feels that there's a spotlight on it when it's with children. And then what we've noticed, and again, I'm sure that you're all aware of, is that our increase in eating disorders, that has doubled. And not only have the referrals increased massively, it's the acuity of presentations as well. Children are much poorlier when they're coming in at first presentation, which is different to pre-COVID. Next slide, Gordon. So what needs to happen next is I've talked about the Neuroways, and what we've got is some additional investment to reduce these ways, and it's for the next 3 years. So it's not going to be a quick fix, but actually it's going to be the fix. So we've got a mobilisation in place that I'm presenting to Ian next week, with posts go out to advert over the next month. What the CCG have funded is to shore up the capacity and demand, but also for the next 3 years provide support to reduce the backlog that we've got. And this is really exciting for Rotherham. We've got the evaluation of the graduated response. So we've got the partnership engagement, and then we've done evaluation of that impact. And that'll help us inform future actions across the partnership to reduce the neurodiversity wave. And then there's the SEMH strategy group. So further rollout of the Anna Freud programme, the partnership approach to social, emotional and mental health in children and young people. And that's where we're working now.
Okay, thank you. That was very excellent. Thank you. Just open up for any questions and comments before we move on to the next presentation. Dr. Mutu?
Thank you, Chris. Jill, just a comment to say the ADHD assessments, the waiting time is so long, and people have the choice of choosing which appointments made with Psychiatric UK. The assessment and follow-up by this Psychiatric UK lacks direction, and they pass it on to GPs, asking us to do prescribing, ECG and bloods and the like. So I just thought I'd bring it to your attention to say, it's not my dog.
It's not mine either. Yeah, so we have had some problems with ECGs and bloods in the different areas, but we've actually procured somebody to do our ECGs, and they will be done we get the results back within a day. So again, that we've sorted that really now. So if that is continuing, we need to probably know. We haven't started yet, but they're imminently going to start.
Yeah. Thank you.
We're just finalising the contracts and signing the details, and then we will be doing that.
Thanks.
Okay, thanks, Christina. Thanks for that presentation. Well, I think it just leads us nicely into the next presentation as well. So if I just invite Ian just to give the mental health update, then we can capture any further questions after that.
Yeah, thank you, Chair. Morning, everybody. I'll just share my screen if I can. Can I just confirm that sharing okay?
Yeah, we can see that, Ian.
Okay, thank you. So, through the Mental Health and Learning Disability and Neurodevelopmental Group, one of our key priorities is suicide prevention. And again, there's a full partnership approach to suicide prevention in Rotherham, and a number of colleagues on this meeting could probably present this, and it just reflects the kind of sign up from all our partners. And again, a huge thank you to colleagues that have worked extremely hard on this agenda over recent years since we chose to really escalate it as a priority. I just thought I'd share with you here, if I can, share some of the areas that are working really well in the Rotherham place. So we have a real strong leadership and commitment to the programme across our suicide prevention, overseen by our Health and Wellbeing Board and our place plan. There's a key suicide prevention improvement action plan that is monitored routinely. We held a suicide symposium a few years ago when we were really challenged in terms of the agenda. And more recently, just on the 12th of October, we held our second suicide symposium with national speaker, Professor Nav Kapoor. And I think that allowed us just to reflect on the journey that we've travelled, but also as the agenda changes on suicide prevention, some of the actions that we need to take and really keep this the highest priority in the Rotherham place. And I'll come back to that shortly. More recently, we've chosen to work with our voluntary sector provider in terms of VAR to work on our small grants and enhance our small grants programme. that offers out grants to voluntary sector organisations that work with small groups of individuals to support in this area of mental health. And that's been really, really successful. But we have managed to land that now for a 3-year period, which gives the voluntary sector more sustainability in how we manage the programme. We've since you last had the update, we've launched our Be the One programme across the Rotherham place in terms of the women's campaign. We'd focused a more generic campaign in previous years. We've also launched an online support mechanism around Rotherham. That's been really successful, both for our Rotherham residents, who we've had significant activity on Rotherham, but also now we've released a professional section to offer support and advice to professionals who need that support to support patients in our community. We've also continued to develop our support for those that are bereaved by suicide. We're expecting a new peer support group to go live from December this year. Many people will know that we commissioned the South Yorkshire Suicide Listening Service, and we're looking to recommission that at the moment. We've moved within our local arrangement with primary care to bring suicide prevention into our primary care quality contract, developing top tips for GP colleagues, and they're routinely updated. And again, we've seen a reduction in all-person suicide and male suicides from 2018 to 20. And we're actually playing an increasing prominent role across the South Yorkshire footprint with regards to suicide prevention. I suppose what are the key areas that we want to keep focusing on? We absolutely want to maintain this as a priority in Rotherham. It's got to be up there with our key priorities across the place. And again, a big thank you to partners across the place for continuing to prioritise that work and advocating this agenda. Again, we've just commented there around our real-time data. We didn't show an increase in suicides in 2020. However, when we talk around protective factors linked to the pandemic, we know that these are coming out of the system at the moment, whether people are coming off furlough, whether there's challenges in terms of employment, etc. So we really need to be mindful of that and are working through that in terms of our approach locally. There's just some data there in terms of addressing inequalities. And again, we'll be feeding those through into our action plans going forward. We talk around these life events that have come out in our audits of suicide prevention through our operational group, around relationship issues, work-related issues, housing issues, etc. So as well as working on that agenda, we're trying to point that discussion into those areas of our place around where we can continue to support. Our listening ear, which is our general bereavement service, will be funded until June 2022, and I'll come on to that in a second. And again, the funding for suicide prevention training is not recurrent, so we'll need to continue to review that and the effectiveness of that, because we have rolled some significant elements of suicide prevention training out over the recent months and years. Okay, just moving on to what needs to happen next. As I said, we had a really constructive symposium that brought all partners. It brought different professionals together and also users of partnership and patient representation into that session in October. And we're now reflecting on that in terms of how we'll adjust our action plan going forward. We are looking to pilot a service to support those individuals who have attempted suicide, because we know that is absolutely an at-risk group. So we're working through that proposal at the moment. I think a lot of our dialogue at the moment across the partnership has just raised our awareness around our strategy for bereavement support and what are we going to be doing in the future around our bereavement offer in the Rotherham place. So there's definitely a piece of work to be doing there. We're also actively commissioning an alternative to crisis procurement, to crisis services, and we're looking out to procure that from now, and it'll go live in spring 22. Apologies, there's just a slight error in terms of the dates there. But this is us probably looking towards more voluntary sector approach in terms of supporting crisis response as opposed to traditional services that we might have used in that service. And then just finally there, we are going back out to procure our South Yorkshire Suicide Listening Service, and that'll be completed to go live from February 2022. So lots of positive activity in the space of suicide prevention, although it's one of these areas that we don't ever want to kind of drop down our priority list as partners. And again, thanks to College for the support on the agenda.
Thanks, Ian. So, comments, questions, anybody, before we move on to the next agenda item? Anyone happy with those presentations? Okay, I'll keep us moving then. So we've got the next update just under this section of the transformation groups. It's from the urgent and community care group. So it's on sustainable discharge. This is down for Michael and Anne-Marie.
Michael, do you mind? I'm having problems with I don't know if Michael's there.
Yeah, sorry, no problem, Anne-Marie. I can go through the presentation. Gordon, could you load it up, please? It seems far quicker and more efficient when you do it.
Yeah, I'm just doing it now, Michael.
Thank you.
Can everyone see that?
Yeah, thanks, Gordon. So the spotlight is urgent care and community, and we're looking at sustainable discharge today. And there are a number of good news stories locally that we can tell. So if we just click onto the first slide, please. So in terms of what's working well, we've got a really strong partnership working. We're integrated discharge team of the year across the South Yorkshire Teaching Partnership. Also, the integrated discharge model that we're operating across the trust with RMBC was highly commended within the recent CQC report. We've got that. We've developed the command centre, an integration acute site team, which we've also developed the place capacity dashboard. The command centre is really impressive. It's on D floor here at the trust, and we've got quite a shared area with RMBC colleagues and our own staff here at the trust working together collectively. It's essentially a nerve centre, and it's really adding some value. We've got the highest weekend discharge rate in the region. The national discharge standards met, no DSTs completed in acute setting. We've got a preferred supplier for 24-bedded community unit with nursing, which is now approved. Arrangements in place with Sheffield for COVID positive beds and Scheme 2 funding. And the table on the right hand side just gives you an indicator of the discharge by pathway and where we are against the national target, which is pretty positive really. Leading on to the next slide, please, Gordon. We talk more about what we're worried about. So we've had unprecedented demand on the system in the summer, increased complexity, and the impact of winter is a major concern. In terms of COVID, we've seen increased rates, particularly over the last few weeks, the highest in the region, the top 5 nationally for the over 60s, and this is clearly playing out in terms of the number of positive inpatients here in the trust. And also there's a forecast rise in other infectious diseases, for example, flu, norovirus and respiratory, which is ultimately going to make it a really challenging winter going forwards. We have national and local challenges around staff recruitment, so there are certainly some capacity issues around domiciliary care and reablement and hospice, which is ultimately impacting on how we can manage the caseload that we have. We've got increased use of community beds, which does have an impact, and we can see this increasing actually. And then, if you thank you, Gordon, on to the next slide. We have a number of case studies there. So the Age UK Safe and Well pilot, the brief was to provide follow-up calls to over 60s following discharge to ensure that the patients are safe and well at home. And we've got some stats there, just reading down the middle in terms of the number of referrals, which is circa 4,000 and 3,000 follow-ups. But also listing some of the areas where we're adding value, and that from benefit checks, fire safety checks, door-to-door follow-up services, referrals to Rotherham care, meal delivery and assisted technology. And around the edge of this slide, you'll see some case studies which are really positive outcomes for what were initially seemed to be quite challenging circumstances for our patients. And then moving on to the final slide. So what needs to happen next? I mean, clearly recruitment to vacancies, looking at additional winter roles, continue to develop alternative ways of working, and continue to work collaboratively with between TRFT and RMBC to improve discharge processes, complete ward by ward improvement programme, complete review of trust discharge coordinators, review IDT processes and enhance discharge information, and look at an enhanced MDT, that's multidisciplinary team working at AFO which is where our community beds are. We're looking at procuring winter beds and developing sustainable 7-day discharge processes. We're also going to focus on meds management as well. So there's a lot that we've got planned to do that's already got traction that's going to ultimately improve the process, I think, that we've got here. At that point, I'll pause and take any questions. Thank you, Gordon.
Thank you. Anne-Marie, anything you want to add?
No, I think, I mean, obviously some things have changed since we've written the slides, but overall, Michael's covered every point. Thank you.
Okay, thank you both. So just open it up for any comments or questions, anybody? Okay, so thanks for all those updates, everyone, much appreciated. The format was excellent on all of them, so thanks for that. I'm just going to move us on now to the future spotlight sessions we've got planned for the group, Ian. Do you want to just update us on that?
Yeah, thanks, Chair. So what we said we'd do is to just try to get back into the rhythm of the kind of routine priority updates. So we've working out of the delivery team, we've pulled this schedule together. So much for board members, just to note that we'll be bringing these items through, and also for members of the public if they're interested in specific items that have just got a forward look. So just a note really today, if we can, Chair.
Okay. Any comments on that, anybody? Well, okay, happy to note that. So thanks, Ian. So just on terms of our agenda then, so the Provider Alliance update we're going to pick up next time, defer to our next meeting. In terms of the action log and the draft minutes, Lydia, is there anything we need to pick up on the action log?
Hi, Chris. No, not at all. No, we've got just forward agenda items, really, to be honest. So it's all fine.
Okay, and in terms of the draft minutes, is everyone happy with the minutes to take them as an accurate record of the meeting? I've got some nods, just count to 3. Okay, we'll take those as an accurate record as well then. Thank you very much. So we've got under communication to partners. I'd just like to be slightly different this time in terms of how we treat this. I'd like to go around all partners because there's a recognition that the system's under extreme pressure at the moment. So what I'd like to do is just understand where we are, get a baseline from everybody where we are in terms of system pressures, and then have a quick discussion about how the place board could put in place any mitigations to help partners in the partnership. So can I start with you, Catherine? Could you just give us a high-level update on system pressures from an RDASH perspective?
Yeah, thanks, Chair. So we've probably now for quite a few weeks, if not getting into months, been at really high levels of occupancy within our inpatient adult and older people's facilities. And there's certainly no sign of any let up. Our acuity levels are incredibly high. And I think when you couple that with the pressure in the community, staff sickness, and we're operating with about between 9 and 10% on a regular basis of staff who are on sick leave at the moment, and we are carrying quite a number of vacancies. All of that is adding to the pressure, and obviously having been in the pandemic now for many months, I just think there's a general fatigue amongst the workforce. We have taken a decision as a board to purchase out of area beds, which is not something we ever want to do lightly, given that you are in effect sending people away from their local communities. But in order to ensure that people have access to a safe environment, we've had to do that, and we're continuing to do that for the next few months to ensure that people have got access to the right levels of care. So generally a very overwhelmed system. As Christine has already mentioned, we're seeing really high demand for our CAM services, and our eating disorder service it has been completely overwhelmed in terms of both supporting children that are admitted into paediatric wards, but also trying to maintain people in the community. So just generally feeling very under pressure at the moment, Chris.
Okay, thanks for that update, Catherine. What I'll do is I'll ask members to give similar updates. So can I next go to Michael Wright from a hospital and community service perspective?
Yeah, thank you, Chair. Similar story as our RDASH colleagues at the moment. So we are certainly under pressure around the number of COVID patients that has recently increased. That's now roughly 60 positive inpatients, and it did drop off a few weeks ago, so it has started to ramp up. The number of those patients from critical care is currently 7. If you look in total, we've had over 3,300 positive patients through the trust since the start of the pandemic. And ultimately, it does have an impact on the health and wellbeing of staff. You know, I think staff, as in most organisations, are tired now. More recently, we've had pressures through our urgent emergency care centre with the volumes and acuity of patients coming through, and that's resulted in some long waits. Patients are in our urgent emergency care centre, and because of the COVID patients as well, that's impacting on the potential for flow, because we have 13% of our bed base taken up by COVID positive patients. So it's really challenging us, and as we said earlier, I think winter's going to be an exceptionally difficult winter this year. Thank you.
Thanks, Michael. Can I come to Anne-Marie next for a social care update?
Thank you, Chair. A very, very similar picture. Workforce and retention, whether it be within the actual council or the wider market, is a significant issue, which is causing pressures in terms of morale, but also just trying to deliver the service at the right level. And that is affecting hospital flow at this point as well. We continue to try and prioritise discharges and palliative care referrals, but it's reprioritising and reprioritising at this moment in time based on the resources that we've got available to us. Thank you.
Thanks, Anne-Marie. Shafiq, can I come to you next?
Thank you, Chair. In terms of the voluntary community sector, we have our online directory Gizmo, which we're continually updating. So what we're seeing a continuous number of BCS organisations who are standing back up their services, albeit looking differently in terms of their size and in terms of what they're able to offer. Because in terms of we know COVID hasn't gone away, but that has impacted on the number of staff and volunteers within BCS organisations. But what we are seeing is that our online directory is about 75% updated at the moment in relation to group activity and what services are available. The number of volunteers that are coming forward isn't at pre-pandemic levels, and the number of volunteer opportunities are also reduced. So again, we're working with the VCS organisations and the public at large to increase the number of volunteering opportunities and those people coming forward. As we head in towards Christmas, we normally have a campaign around supporting our food in crisis organisations, those organisations that provide emergency food parcels. And I'm pleased to say that we've got funding from a number of sources to support those organisations to ensure that they have their supplies and the essential that they need to be able to provide the emergency food parcels. There's some certainly other good news in relation to small grants. The CCG has made available small grants for up to 3 years for VCS organisations, particularly around supporting mental health and preventative work. The local authority have made available small grants around supporting communities in standing back up again in terms of COVID and premises issues. And our lottery bid in Rotherham, Smiles for Miles, working with the Children, Young People and Families Consortium, which is providing support, social, emotional and mental health support to targeted young people in communities, is now live, and those organisations are able to take referrals to support young people. And we have worked with NHS Property Services and the CCG to invest funding in a Roe Marsh premises, which is coming on stream next week, to increase social prescribing and work support activity to Roe Marsh Barbet Avenue. So lots.
Yeah. Brilliant. Thanks, Shafiq. Dr. Mutu, would you be able to give a primary care perspective?
Thank you, Chris. Just to say that general practice is under immense pressure at the moment. The demand is mainly for day appointments on the day, basically. It could be either for a face-to-face, it could be digital, it could be a request for advice, anything, but the pressure is really quite heavy at the moment. The hot site, the visiting teams, the extended access, all are running to full capacity. To mention the hot side, that gets filled up by 11 o'clock in the morning. And the rest of the hot patients really are being absorbed by general practice. The big worry really for general practice is the convergence of both the flu and the COVID escalating as well during the winter months. This, according to experts, is almost inevitable. So that's something which we need to be prepared for. Lastly, I'd like to mention the staff fatigue, just like the other colleagues are facing with their teams. That's been quite heavy on general practice because now we are after 2 years of facing this, and the demand for staff is very difficult to replace because you can't get receptionists or healthcare assistants or nurses to fill the gaps, even through local agencies. So that's it really, nothing more to add. Thanks.
Thank you, Dr. Mutu. Can I just come to Ben from a public health perspective, Ben, and perhaps if you could give us an idea in terms of, you've brought it up already, in terms of the prevalence and what we expect to see going forward.
Thanks, Chair. Yeah, so this graph on screen at the moment just shows case rates. So overall in dark blue, under 60s in pale blue and over 60s in red. It's the red line I want you to really focus on. So what we're seeing at the moment is the waves we've seen since, well, the football in July, and then schools returning in younger people have started to now transfer through into the over 60s population. And we're seeing, although we're getting a decline in overall case rate at the moment through half term, we're seeing that the over 60s population is still on an upward trend, and you can see they're back to very close to where we were in November last year in terms of case rate in the over 60s. And that's obviously our most vulnerable population and most likely to lead through into hospitalisations, so and GP visits, etc. So just exacerbating those system pressures that others have talked about. And this is our numbers in the trust, and you can see mid-October we were sort of down to 32 cases in the trust, which has still been high, but a little bit more manageable. Since then we've gone up to where we were yesterday, which was 61 cases in the trust, and we can see we've had sort of 2 or 3 steps between 16th of October and now as that case rate in the over 60s has gone up. So I think that's what's most concerning to me at the moment, is that return to sort of high rates of hospitalisations in our community.
Okay, thanks, Ben. So what I'm going to do then is I'm going to take an action as chair to convene a meeting next Wednesday so we can talk about our governance processes, so we can work as seamlessly as possible as partners and see if our arrangements are appropriate. So I'll take that as an action to convene at that meeting. Gordon, is there anything in terms of communications to partners that you think we need to pick up?
Thanks, Chair. I think what we need to do is just do a bulleted summary of all kind of what's just been said, really, Chair, and send it around partner organisations. I think individual partners obviously working across the system, but the pressures within each of the organisations, it's just good to reflect that the whole system's under pressure and sharing that with organisations. But I think also sharing that with the public. I mean, obviously this is live streamed, but actually sharing that wider with the wider public would be good. So we can use that bulleted list to share that through partner communications, i.e. social media, websites, and other means. So I think that would be good to do that. And obviously that linked into our intercommunications about actually, yes, we've got pressures, but what do we want the public to do in terms of accessing help and services when they need it? So that links very nicely to that work that we are doing now and will continue to do over the following months. So there were the 2 actions that I would suggest that we do from what's been said, is share that within our organisations, but also with the wider public.
Okay, just pause there, and just if anyone's got any feedback, reflections or suggestions, please, now's the time. Catherine, do you want to come in?
Thanks, Chair. It's really interesting just hearing the whole system response to the question that you asked. And I do wonder, Chris, alongside of the suggestion you've made about looking at the governance, whether there is an opportunity for us to think a little bit differently about the way in which we're delivering some of our services. And what I'm particularly struck by is when Shafiq was talking, and it sort of reminded me of some of the mental health voluntary services that we've lost as a result of COVID. And I know that we're seeing much more demand in our own organisation because some of those voluntary services are no longer provided. And it's making me think, you know, I probably need a conversation with Shafiq about what more can we do as an organisation to be supporting the sustainability of the voluntary sector, because it isn't always appropriate for people to come into specialist mental health. But actually, if we thought a bit differently about access and whether or not we can create some different solutions. So whether that's a conversation we all can have next week, Chris, alongside of the governance, or I'm very happy to meet up separately with Shafiq to see if there's other things that we could be doing.
Yeah, I think so. The way I'd express that is I think next week we need to challenge ourselves to think differently about how we approach the challenge ahead of us, don't we? And that's in terms of, is our governance fit for purpose, and is the way we deliver our services fit for purpose as well? So I think if we have that session, I think we just need to turn a mirror on ourselves, don't we, and accept this is an exceptional year and an exceptional period, and it's a different way of. So brilliant, thank you, Catherine. So if we pick up those two perspectives when we meet, Shafiq, do you want to respond to that?
Thank you. More than happy to have that conversation, Catherine. We are working with Ardash colleagues in a number of arenas, looking at exactly what you say in terms of those pathways that can actually prevent escalation into clinical services. But happy to have a conversation.
Okay. Anyone else before we finish off that agenda item? So just to clarify, extreme system pressures across all partners. Ben, as Director of Public Health, giving us the message that we're going to have a sustained period of high infection rates. And obviously we know norovirus and flu will be circulating as well with the normal winter pressures. So I think we need to be assuming at least for the next 6 months, we're going to be under extreme pressures. So we'll have a meeting next week, which will stress test our partnership working, and we'll stress test the way we deliver services to see if we can make sure we get the best possible services available to Rotherham patients over the next period. Is that okay? Thanks, everybody. So, Gordon, anything else you want to add before we finish off? Okay. So risks and items for escalation. Anything else we haven't covered that anyone would wish to raise? Now's the time. I think we've probably done that just under that agenda item, haven't we? So just looking at future agenda items, we'll have to make a judgment about whether we have a public meeting in December or not, and maybe January when we do that. We'll have to make a decision on that. But the future agenda items are the future, how the Rotherham place will fit into a newly created integrated care board, which forms on the 1st of April, subject to legislation. A Rotherham intermediate care development plan update. An IT digital update, provider collaborative update, which we deferred off this agenda, and then transformation group update, if people can just highlight if there's any areas you'd particularly like us to spotlight next time. My working assumption is that we'll have a development session in December and then meet publicly in January. So if that's okay with everyone, that's the working assumption. So just if people can be aware of that. Otherwise, I shall call the meeting to a close, and thank you all for your participation, and thank you all, and have a good day, everybody.
Thanks, Chair.